So some of the common injuries that we face by my athletes during their rigorous training, their training schedule, and their own individual training with their coaches, I shall touch on it. So as all of you guys know, sports climbing is a very physically demanding sport that encompasses strength, flexibility, and endurance, especially all the three different disciplines. In sports climbing, there's three disciplines, basically boulder, lead climbing, and speed climbing. Okay, so as they push their limits to reach their peak performance and to get the best result, so they will naturally exert more. So that's when a lot of injuries will come during training, comp simulation, and also in the actual competition. And recognizing all these common injuries which they face and understanding the mechanism of it, and collaborating with MYSI and SSI help us to provide a support system for the athletes to be able to turn to doctors, sports doctors instead of a GP who might not understand their needs and their injuries as much as more specialized doctors. Yeah. So some of the common injuries, type of climbing injuries would be acute traumatic injuries, mainly falling from height, like in boulders when you do a dynamic move from one hole to another, like a double dyno, where you just slip off from one hole to another. Then when you caught onto a hole, because of the momentum and the swing, you peel off the hole that you're going for, and you might fall face first, or you might fall in an awkward position. So usually this kind of injuries will be more of like impact from the fall, sprained ankles, or shoulders dislocation, fractures, and in some cases lacerations and abrasions. We shall touch on it more later part in the presentation. Overuse injury, meaning it's a gradual build-up of stress and wear and tear to your various joints like finger joints, elbows, knees, and maybe even hips, without sufficient time to rest, without proper stretching, and without proper recovery time. So some of the common ones would be finger pulley strains, shoulder impingement, tendonitis in various areas, and knee ligament stress. Okay, some of the factors and causes of sports climbing injuries would be inexperienced climber, which it shouldn't be for the national team, but for the more leisure and casual climbers, they would experience this because they don't know how to fall properly, especially when from a boulder wall. Inexperienced belayers for lead climbing, especially for those who just got their so-called sports climbing level 2 certification, they might not be able to catch their falling climbers efficiently and give them a soft catch to prevent injuries. Environmental factors like poor quality mat or the crash mat that is being very worn out, where there are many cases where in competitions which I was the chief judge or jury president for, inspected some of the mats. So basically the density of the crash mat is no longer there. So it becomes like very soft and very hollow. And that presents a very big safety concern, because if the climber falls coincidentally into that particular spot that is like a pothole and it's not dense enough, and that will result in quite a fair bit of impact or trauma injuries when they fall, especially when they land on their back. So that's why it's very important that usually for competitions, we will have medical support, Alpha Bravo, together with medical attendants, with the proper stretchers, spinal boards, and everything to be able to manage the mechanism of injury, which in this case will be fall from height. Poor climbing technique and form, which sad to say is also quite prevalent within the national team, because some of the climbers who are physically very strong, so they will use their physical strength to overcome their lack of technical skills, and sometimes when they overcrank it, they will you dislocate shoulders, or they pull their pulleys or pop their fingers in a way. Inadequate strengthening and training regime. Some of the climbers, I don't see, okay, the national team, usually we don't have this issue of inadequate strengthening of training regime. That would be the other end of it, would be overtraining. So there's a lack of rest time for the muscles, for the body to be able to recover so that before they embark on the next training. Lack of consideration for age-specific factors in implementation of training regimes. So in this case, a very clear-cut example would be like from our category, Youth C and Youth D athletes. They are mainly below 15 and below 13. Some are as young as 10 or 11 years old. So they are relatively very young and their body is still developing and maturing and growing, especially their bone structure. So I've seen some of their personal coaches in the bid to push for their physical strength to be greater. So they start to implement load bearing for their climbing. Like they will do wear weighted vests for their pull-ups, wear weighted vests for their climbs and everything, which is I think is not ideal because their body is still growing and it will stunt their personal growth as well lah. So these are the things that usually we look out for as the NSA when we go down to see our athletes train with their private coaches. Inappropriate training frequency, that will be more akin to too much training. Sometimes when some of the athletes, they have private coaching on top of the national coaching. So if our national coaching is like 1, 3, 5, and 7, so in between they will slot in their own personal coaching the day after, or maybe even on the day itself, which means maybe morning we'll go for national training, then evening they'll go for their personal training. So there's not enough rest time for them to recover, and that's why a lot of injuries happen as well. Because and also the personal coach might not understand that, might not check back with the national coach what they have been doing in the morning. So sometimes they will repeat the same training again in the evening. So that will induce a lot of stress on the particular body part unnecessarily. So untreated chronic overuse injuries. A lot of the climbers, once they have injuries, right, they really just sweep it under the rug. So they'll just train through it. So they will usually just go for some massage, some so-called quick fix, slap goyo, the typical kind, and hope that next day, or maybe some even go more extreme, they take some painkillers, to numb the pain and carry on training the next day. The ergonomics of footwear. Some of them, this is the funny part. So some of them will wear climbing shoes and walk around the gym and everything. As you know, climbing shoe is not a very stable footwear for normal walking. So sometimes when they move around, they rush around from point to point to do their training, right? Some of them just roll their ankle and get injured. Finger injuries, basically the nemesis of the climbers. So some of the common injuries, which would be pulley tears, tendonitis, and I think most of the panel will understand these two injuries, the mechanism of it more than me. So I shall not touch on the two injuries. So the treatment basically is really what we are targeting at, and we'll refer our climbers to get an appointment with a sports doctor through NYSI and SSI, so that they can get their injury assessed and treated accordingly, and also begin on their physiotherapy and recovery process. The upper body injuries, common ones which we are usually seen is shoulder injuries, which I just, one of my team members just had one, Glenna Tan. So during one of the open national comps, she fell off the last move in an awkward position, and it seems like a hard fall, that's all. But it turns out to be a shoulder labrum tear, which requires surgery and weeks of rehab. And it happens at a very inconvenient time because we're going for SEA Games selection. So these are some of the things that injuries can really throw a spanner to the athlete's career. Elbow injuries is tennis elbow, climbers, and also golfer's elbow, basically. When they climb a lot and they never rest and they get inflamed, and that's some of the common injuries that we face. Even for younger kids like C and D, they do complain of such injuries as well, despite being so young. Wrist injuries. Some of our athletes, they do a secondary sport, like some of our climbers are gymnasts. So gymnasts also have a very strong emphasis and usage of wrist as well. So when it comes to climbing, they will also have a lot of stress on the wrist. So they resulted in quite a lot of injuries for some of my climbers lah. Treatment protocol, strengthening exercises. Mainly we work with S&C site strength and conditioning for through NYSI and SSI, their strength and conditioning coaches, and we will cater to the individual athlete, like what they are lacking in and what they are weak in, and they will come up with a training plan to help strengthen that particular weakness of theirs lah. And some of the athletes that are coming back from surgery and from injuries, right, they also work with them in the process of rehab as well. In lower body and hip injuries, mainly will be knee injuries due to the ACL, MCL tear when they fall from the root. I have a climber who did a particular heel hook, right heel hook to go up to the next move, but when he fell off, his leg, or should I say his right heel, is still stuck at the climbing hole. So you can imagine that his upper body or 3/4 of his body is falling off, but and his right ankle and right knee is still lodged at the heel hook position, and that resulted in quite a bad injury lah. Basically, he suffered a full tear to the MCL, ACL. Head trauma, like I said earlier on, one of my climbers fell off the last move, going for a big move, and fell, and she was disorientated for a while when she crashed upon the mat face first. The ankle injuries, which I touched on earlier on, and foot and toe issues. This is a very unique problem, which I think I just saw recently, will be toe injuries. I have two speed climber who having toe injuries. Because speed climbers, as you know, for their sport is a lot of speed, and they're pushing off their toe a lot when they do repeats and repetitive moves, and in segments like sprint repeats for those short distance sprinters. So they complain of their big toe feeling the strain and pain of it lah. So and it resulted that when they train on, they thinking that it's just a stress or strain on it, and they train on, and they realize that the pain is getting worse. And when they go for a scan, it actually turned out to be they have a slight tear in the tendon, the big toe, and also they require to go for some electric therapy, shock therapy. But it doesn't seem to be working lah. So we are trying to resolve and see how else we can best support them on their road to recovery. Injury prevention, I think for the timing injury prevention, I think first and foremost, I think the rest and recovery, you must have adequate rest lah. I think same goes for all sport. Enough rest, sleep early, which is also a lot of athletes don't sleep early. Usually they'll stay up quite late at night, and we will encourage them to rest more so their body can heal. Comprehensive warming up. So this is also another big point for a lot of athletes, is they do not warm up enough, thinking that just the basic stretch and static stretching will suffice for their sport, for the training they're going through for the day. So maybe for a reference, when they go for competition in the actual boulder, most of the climbers, experienced one, will be warming up about at least 45 minutes to 1 hour before they get into before they loosen up, especially the hip mobility and their flexibility. Technique training. So the national coach will usually work on all the basics, basically footwork, proper engagement of muscles, how to engage your shoulders and everything, so that a lot of time where they do big moves from one point to another, they will curl inwards with their shoulder and tend to pop their shoulders. So on our end, the national coach will teach them how to prevent all that and how to execute the proper technique for climbing, especially shoulder moves, how to place your toe in the correct position, and etc. And how to really stretch and open up your hip flexibility. Strength and conditioning, basically we're working with the MSI to focus on areas where they are weak in, especially their certain muscle groups which they don't really use a lot. So with all that in, then we'll be able to reach our peak performance lah. Okay, just for a little bit of sharing, how NYSI and SSI support the national team. The small picture over there basically is our latest competition, IFSC Asia Cup in Hong Kong, where our women's team did very well. They basically attained the necessary data point to qualify them for the SEA Games lah. Yeah. So just put it, I just focus on what they, okay, the first thing will be the carding. Okay, the national team, basically all national athlete from Youth B onwards will be carded. Right. So for the seniors, right, basically they will be carded from the basic carding all the way up to E1 lah. So with each level, they will be provided different level of support. So going towards the carding, so once they get injured, so if they have a need to see a sports doctor, to get appointment to get a doctor to look at the injuries, right, they will just go through protocols and approach or they approach the NYSI manager, which is currently Mr. Louis or Shi Ying from NYSI SSI. Then they will be able to book an appointment with the sports doctor, NYSI SSI sports doctor. So after the appointment, they will book, they diagnose the injuries, then they will recommend the plan for rehab accordingly. So the amount is, there's a cap amount lah. Usually our climbers won't be able to so-called go past that amount lah. And usually they also not so particular about it. As long as our climbers, there's a need for our climbers to have access to the medical support, right? They will just give their full support. Yes, that's the end of my slides lah. So I think I got one more part to share will be on how the climbing community is supporting sports climbing in our pursuit for the SEA Games lah. So for climbing gyms like Fit Block, BFF and Boulder Plus, they allow the national team to train there for free. So during our national training, right, as long as the national coach is able to book a slot at the respective gyms in advance, they are allowed to climb there and train there for free without so it's complimentary. So even during their own free time, the climbers can also have access to the gym complimentary as well. So it's part of the program that we are working on to work with more gyms to have allow our national climbers to have access to more training facilities lah. Because as you know, sports climbing, we don't have a huge budget, and our national training center is currently at NYSI at Stadium Lane, and we do not have boulder wall. We have a small lead wall and a speed wall, and that's it. And it's really, really not enough for them to be able to push for elite performance. And that's why we are working with all the commercial gyms to ask them to help us. And it's been good. So far, we have been working with 3 gyms, and we are looking to expand the number of gyms we are working with lah. And all these gyms, they don't ask for anything back. Basically, it's just want to help the nation to grow the sport as well lah, and to help us push for SEA Game medals. Yeah. And yeah, that's about it. So any question from the ground with regards to sports climbing or the development of sports climbing?
Right, so Dr. Lim Jin Xi is a senior consultant and head of the Department of Hand and Reconstructive Microsurgery in Fong General Hospital. After obtaining her medical degree from NUS Medicine in 2009, Dr. Lim went on to complete her postgraduate hand surgery training in NUH. Her clinical interests are in chronic wrist conditions, sports injury, and wrist arthroscopy. Besides providing clinical care to her patients, Dr. Lim is also actively involved in research and has published various articles in international peer-reviewed journals. Dr. Lim's current research interest is in surgical education, and she has been awarded various grants for her research projects. She has also been invited to speak at international and local hand surgery conferences, presenting topics on reconstructive surgery. She also believes in keeping fit and is active in the local sporting scene. She plays floorball for a competitive floorball club. Without further ado, hand the time over to Dr. Lim, please. Thank you.
Hi, good afternoon, everyone. So I'm honored to be here today to share insights on hand and wrist injuries in climbers, a topic that is becoming increasingly relevant as climbing gains popularity. So I'm Dr. Lim. I'm a senior consultant in a hand and reconstructive microsurgery department of the National Health System. And I practice in Fong General Hospital usually, but I also have practiced in National University Hospital and Jurong Medical Center. So before diving into climbing injuries, let me first give a brief introduction to hand surgery, what we do, and how our work extends beyond just treating hand fractures. So as a hand surgeon, I manage a wide range of conditions, from common lumps and cysts to complex trauma cases like finger amputations and dislocations. Let me share some examples. Like this is a case of an index finger amputation. So we successfully replanted the finger, and the photos on the right showed the patient's recovery 7 months later, regaining good function. Here we see a malrotated finger fracture of the little finger. We realign the bone and stabilize it with pins, allowing it to heal in a functional position. Our expertise extends beyond hands actually. So we handle microsurgical nerve and vessel repairs for complex lower limb injuries as well. And we even assist in liver transplants when the vessels are too small for the transplant surgeons to manage. In cases when a digit cannot be replanted, like in this case, the patient's left thumb, which is his actually the dominant thumb, couldn't be replanted. We perform toe to thumb transplantation to restore the hand function. So this is actually the patient's second toe. So imagine life without your thumb. There's a lot of things you can't do. So after transplanting this toe, the patient could regain very good function of the hand. He could write and he could even spin a pen. Okay, we also treat patients with hand deformities, infections, and congenital hand differences. Hand surgery is about restoring form and function, helping patients return to their daily lives, whether it's about performing routine tasks or specialized activities like climbing. With that, let's move on to today's topic, hand and wrist injuries in climbers, what to look out for, and how early intervention makes a difference. I believe there are both healthcare workers and non-medical climbing enthusiasts in the audience, so I will try my best to make my talk as simple as possible. So climbing has seen a surge in popularity with about 25 million individuals participating regularly. Over the past decade, climbing facilities have increased by 50%. Climbing was also included in the 2020 and 2024 Olympic Summer Games, leading to an increased interest and emphasis on improving technical skills and subsequently also a rise in climbing-related injuries. For rock climbers, the overall injury rate is about 4.2 per 1,000 hours, with a career incidence of 1.5 to 4.4 injuries per person. The upper extremity accounts for 42 to 70% of all injuries, with fingers being the most commonly affected site, followed by the shoulders, wrists, and elbows. So among all climbing injuries, about 37% are referred to a hand surgeon, and of this, half of them require surgery. Just a note that most of this data are from America. I don't have local data here. Climbing involves a series of repetitive, static, and dynamic movements that demand strength, balance, and precise body positioning. So indoor climbing has introduced more technical routes, including 3D problems and overhanging walls, which place even greater demands on the upper extremity. Climbing frequently suspend their body weight from their arms, subjecting their hands and wrists to high loads. Hand surgeons are expected to see more climbing-related injuries in the coming years. Understanding the sport, accurate diagnosis, and appropriate treatment are key to helping climbers maintain their performance. So like Jeff mentioned just now, there's two main types of injury. Traumatic injuries result from falls, wall collisions, or excessive force on a body part. Overuse injuries develop from repetitive movements and are more common in indoor climbers. So each joint in the hand can suffer from overuse due to sustained gripping positions unique to climbing. So this includes special grips with the fingers, chronic loading on the thumb, increased loading on the ulnar side of the wrist, and repetitive and sustained flexion of the elbow. They all can cause unique injuries to these areas of the body. So climbing can result in injuries to tendons, ligaments, bone, and nerve compression syndromes. And this is a list of the more common injuries unique to climbing. Over half of all climbing-related hand injuries involve the flexor tendon pulley system. So the flexor tendon pulley system is a tunnel through which the flexor tendons of the finger passes. So they play a crucial role in stabilizing the tendons against the bone, allowing efficient force transmission from the muscle to the digit. Okay, so this is the tendon, and the yellow parts are the pulley system. So this mechanism is essential for generating a rotational movement required for gripping. Among all grip types, the crimp grip places the highest stress on the A3 pulley, okay, at the proximal interphalangeal joint. And this makes it particularly vulnerable to injury. The ring and middle fingers are most commonly affected due to their anatomical and mechanical positioning. Pulley injuries frequently occur during an unexpected fall when the climber instinctively tightens their grip. So this sudden increase in force can exceed the tensile limits of the pulley system, leading to partial or complete ruptures. Climbers with a pulley injury often report an audible snap or tearing sensation at the time of injury over the fingers. Okay, immediate pain, swelling, and bruising over the affected area, and loss of grip strength, discomfort especially when trying to grip or bend the affected finger. So in cases of multiple pulley ruptures, more severe signs may appear, and this include clinical bowstringing, which is when visible displacement of the tendon away from the bone can be seen, and loss of full finger flexion. While pulley injuries are primarily diagnosed clinically, imaging may be useful in uncertain cases. So ultrasound is usually the preferred modality as it is cost-effective and allow for dynamic assessment. Okay, however, MRI can also offer detailed anatomical insights. So these are MRI sequences of a patient with injury to the pulley system. So in this picture here, we can see there's some fluid around the tendon. And in the sagittal view, we can see in this part where there is an injury, this is the tendon and it's away from the bone. And we compare it to the normal part of the finger where the tendon is actually right next to the bone. So when the pulley is ruptured, it allows the tendon to fall away from the bone and affecting its function. Most pulley injuries are treated non-operatively with rest, edema control, early therapy, and protective taping or splinting, with gradual return to climbing by 6 weeks. While taping doesn't prevent injury, it helps in recovery. It helps to position the tendon closer to the bone such that the pulley system can heal by itself. Non-surgical treatment usually leads to good outcomes, with most climbers regaining their previous level within a year and no significant loss of finger strength. Surgery is reserved, however, for patients with multiple pulley injuries. Like in this case here, you can see the tendon is just lying free and away from the bone. So when we reconstruct the pulley system, the flexor tendon can be working better when it's closely applied to the bone. Tenosynovitis is the second most common finger condition in climbers and most commonly involve the middle or ring finger. This is associated with increased intensity of climbing, resulting in pain over the affected finger. When acute, the diagnosis can be difficult to distinguish from a pulley injury. And we also need to distinguish this from trigger finger, which we are more familiar with. Okay, this video shows a patient with typical trigger finger. The affected finger will be painful and swollen and may also experience blocking or clicking. In cases of tendon inflammation due to climbing, the pain is usually at a different location. So in patients with the typical trigger finger, the pain is over here. But in patients with triggering or synovitis due to climbing sort of overuse injuries, the pain is usually higher up in the fingers. So recommended treatment includes complete rest from climbing, followed by a gradual return to sport, use of medications, and avoidance of the crimp grip. In refractory cases, sometimes we can give some steroid injections. This is a 15-year-old boy who presented with pain of both middle fingers for 2 months. He loves bouldering and does it a few times a week. An X-ray showed injury of the growth plate, right over here. So with competitive climbing gaining popularity among youth, pediatric injuries are increasing. Growth plate injuries of the middle phalanx are common due to repetitive microtrauma and high loads placed on the proximal interphalangeal joint. So injury is frequently missed and continued climbing will lead to permanent deformity. So we don't always get to see any changes on X-ray, and sometimes we may need to do MRI scan to diagnose this. So early recognition is crucial. And a previous study also showed that epiphyseal stress fracture was present in 87% of climbers under the age of 14 who presents with finger pain. X-rays and MRI is recommended for early diagnosis, and treatment involves rest for 4 to 6 months, including a period of immobilization and splinting. Prevention of these injuries is important, with some actually recommending youth climbers avoid high-level bouldering and intensive finger strengthening programs. Lumbrical shift syndrome is a unique climbing-related injury caused by excessive strain on the lumbrical muscles. So this muscle originates from the finger flexor tendons and helps to bend our fingers. So in the first picture here, this is the muscle, and this muscle of the middle finger is and ring finger is special because it originates from both the tendons of the middle and ring finger. So the single finger pocket grip puts this muscle at risk as the gripping finger here remains in relative extension while the adjacent fingers are actually fully bent. And this imbalance pulls apart the third lumbrical's origin and leads to injuries ranging from mild strain to full muscle tears. So climbers report pain only in the single finger pocket grip position, with other grips remaining unaffected. The lumbrical stress test showed here is positive. In severe cases, ultrasound or MRI scan can show swelling or tear of the affected muscle, but imaging can sometimes be normal in mild strains. So for milder injuries, lumbrical stretching, pictured here, prevents scarring, and body taping helps with pain control and prevents overstretching. For more serious injuries, we need 2 weeks of immobilization before starting therapy, with recovery taking up to 5 months. Climbers can usually return to their previous level with non-surgical treatment if managed well. To reduce the risk, climbers should avoid the single finger pocket grips and instead use a 2-finger pocket grip, keeping adjacent fingers extended. By understanding this injury and modifying climbing techniques, athletes can protect their lumbricals and maintain peak performance. So collateral ligament injuries can also occur, okay, and this often affects the middle finger or thumb. So the collateral ligament is the ligament at the side of our joints that maintains the joint in a stable position. So when there's abnormal force acting in one direction, this ligament can tear. Okay, we can see in this video here that the ligament on this side is completely torn and the joint is loose. On the right side of the screen, the ligament is intact, and so the joint does not deform with the pressure that we are applying. So we examine for torn ligaments in 2 positions, with the finger straight and then slightly bent. Partial tears are usually treated with splinting and rest, while complete tears may sometimes need surgeries. Next, we come to carpal tunnel syndrome. This affects about 10% of elite climbers and is worsened by intensive periods of climbing with the wrist flexed. In the diagram here, this is where the carpal tunnel is. Okay, this tunnel contains most of the tendons and nerves going to the hand. The wrist flexion increases the pressure in the carpal tunnel. In addition, sustained gripping causes increased pressure on the median nerve inside the carpal tunnel when the tendons become taut and they press on this nerve here. Symptoms can range from mild intermittent tingling and paresthesia with no weakness to persistent numbness, total loss of sensation, and the hand muscles may also shrink if this is a chronic problem. Non-surgical management is effective most of the time, but in persistent cases, a carpal tunnel release is necessary. So this is a surgery which widens this area here such that the nerve is no longer squashed in this area. It is important to differentiate carpal tunnel syndrome from pronator syndrome, which is a nerve compression syndrome of the same nerve in the forearm region. And this may also happen because in climbing athletes, the forearm muscles are especially well developed. And so the muscle can actually also compress on the nerve in the forearm. Chronic stress on the ulnar side of the wrist, right here, can result in degenerative tears of the ligaments, most commonly the triangular fibrocartilage complex. Okay. Treatment usually starts with rest and splinting. If that fails, a steroid injection into the wrist usually works wonders. Rarely, patients need surgeries from these injuries. If they do need surgery, we usually perform the procedure using keyhole surgery, where we put a camera into the wrist joint to clean out the damaged parts of the joint. Okay, so this is the damaged ligament here. Climbers have a higher incidence of hamate fractures compared to the general population. So unlike direct trauma, which is uncommon in climbing, these fractures primarily result from chronic high contact pressures exerted by the flexor tendons over the hamate bone over here. The hook of the hamate serves as a pulley for these tendons, making it vulnerable to repetitive stress, especially during wrist ulnar deviation, a position commonly used in this undercling grip. Patients typically present with insidious onset of pain and swelling over this region of the hand. And sometimes this is accompanied by numbness of the little finger. Given the overlap in clinical presentation, it is important to differentiate this injury from other ligament and tendon injuries in this part of the hand, like a tear of the triangular fibrocartilage complex, tendinitis of the other tendons around the area, and ulnocarpal impaction syndrome. So each of these conditions can be aggravated by this positioning of the wrist. And the hook of hamate pull test is diagnostic for this injury. However, fractures are often difficult to detect on routine radiograph. So this is a regular X-ray of the wrist. This is the hamate bone, and this is the hook of the hamate. As we can see here, this bone has quite a unique shape, and the area that is shaded red is the hook of the hamate. A carpal tunnel view may improve visualization. You can see the fracture line here. But when X-rays are inconclusive, we usually need a CT scan that usually shows the fracture quite well. While some doctors advocate for excision of the fracture fragment for earlier return to function, some studies show that this can lead up to 15% loss of finger flexion strength in certain wrist positions. And so it may not be so such a suitable option for climbing athletes. So therefore, non-surgical treatment is preferred, and it consists of casting the wrist for 4 to 6 weeks and avoiding climbing for up to 12 weeks. This approach achieves resolution of symptoms and usually allows the fracture to heal well and allows strength to return to pre-injury climbing levels in most of the cases. Surgical fixation is also a valid option and gives good union rate. However, it's a difficult surgery to perform because this hook of hamate is actually about 5 mm to less than 1 cm in width, and there are a lot of important structures around the area. Other wrist fractures can also occur if a climber falls, and this includes distal radius fractures, other carpal bone injuries, or wrist dislocations. So this is one of the most serious injuries I have seen in a climber. This is a 27-year-old male who was bouldering when he fell directly onto the left hand. He had pain over the wrist and the elbow region. He had a minor fracture in the elbow which doesn't need any treatment except for rest. However, the X-ray of the wrist showed this. I have a normal wrist X-ray here to help everyone understand this injury. In the normal wrist, these 3 bones, namely the capitate, lunate, and radius, they should be sitting on top of each other. The lunate bone is named as such because it is a moon-shaped bone. However, in this patient, the lunate bone was sitting in front of the rest of the wrist joint. Therefore, this is a lunate dislocation. And this is a serious dislocation injury of the wrist, and it can be missed up to 25% of the time. If left untreated, the patient can actually end up with a serious nerve injury and will lose the use of the hand due to chronic wrist pain. So I have some photos here showing the findings we have during surgery. The first photo is showing us the contents of the carpal tunnel that we were talking about just now. This is the median nerve, and we can see here the center part is red, so the nerve has been injured during the fall. When we move the nerve aside, we can see that the lunate bone is jutting out right below the nerve and impinging on the nerve. So we replace the bone in their correct position and fix the ligaments and then pin the wrist joint in this better position with wires. About 4 months later, the patient was able to return to resistance training and strengthening exercises. I saw the patient again 1 year after surgery, and he had already returned to climbing a few months ago and had almost full range of motion and grip strength. Injuries of the elbow and shoulder can also occur, although less common. This includes inflammation of the tendons and ligaments around the joints, dislocations, and muscle tears. In conclusion, climbing stresses the hand in unique ways, and injuries can range from minor overuse conditions to complex fractures requiring surgeries from falls. Early diagnosis and appropriate treatment are crucial to maintain hand function and climbing performance. Preventive measures, such as modifying grip techniques and adequate rest, can significantly reduce injury risk. So thank you for your time.
Thank you very much, Dr. Lim. Especially, I really enjoyed your talk, especially the intra-op photos. I think it's not something that we see very often. So thank you once again.
Okay.
Yeah. So while we get Debbie to upload her slides, just a gentle reminder for everyone, in case you have any questions for our speakers, both Debbie and Dr. Lim, we will discuss them towards the end of the session after Debbie has given her presentation. But do please post your questions in the chat group. Yeah. And Debbie, you can share your slides while I introduce
Yep.
So Debbie is a physiotherapist from Singapore with 10 years of climbing experience. She's currently based and practicing in Melbourne while studying health data analytics. She is interested in combining clinical experience with data-driven insights to help climbers stay strong, recover effectively, and climb injury-free. So today her talk will be on injury prevention for the shoulder, wrists, and fingers. While Debbie is still loading up her slides, just a quick reminder for those who may have missed the announcement earlier just now. We actually have our next session planned, our next sports medicine series in 2 months' time. So that would be on exercise physiology by our special interest group, followed by our AGM. Yeah. Okay, so the slides are up. I'll hand the time over to Debbie. Debbie, please.
All right. Are you guys able to see the full screen for my slides?
Yes, full screen.
Sorry about that. Yeah, and the audio is okay too, right?
Yes, great.
All right. Okay. Hi guys. So today I'll be talking about climbing injuries and prevention. So I think because like the previous 2 speakers had gone into quite a bit of detail for fingers and wrists, so I think I'm gonna go a little bit more broad in towards common injuries, recovery, and then question and answers afterwards. So not so specific into hand, wrist, and shoulders, but more towards injuries, what to look out for in climbers during recovery. So common injuries that we usually see are tendinopathy, finger injuries, and overtraining. So these are the 3 main ones that I'll be covering for today. So tendinopathy, what is it? So it's a basically generic description of conditions associated with overuse injuries. So this can range from like your hamstring, from your elbow, or even your fingers. So your tendons are your active structures. So they are the part that attaches your muscle to bone, and ligaments are your passive structure and they attach bone to bone. So the main point in knowing this is to know when to rest. So for example, with a passive structure injury, you need to rest because the soft tissues need to heal, or that's the way the soft tissues heal. And for active structures, it's more towards progressive loading and knowing how to load, when to load in order to maximize your recovery. So main causes of tendinopathy are one reason would be muscle overcompensations due to imbalances elsewhere. So one example would be weak extensor muscles in your forearms, and then you start to overgrip with your finger flexors, which causes maybe like golfer's elbow compensation or like your biceps. Another example would be rotator cuff, and then causing a lot of excessive pulling in, a lot of locking, and causing bicep tendinopathy. So one of the other main reasons for tendinopathy would be acute or chronic overloading way past your tendon's load capacity. So this happens when you load too much too soon, or either that or you have rapid increases in your training volume and intensity. So this can also occur when climbers change from different disciplines. So for example, if you were a lead climber and then you change into bouldering, there's a very big change in the type of loading and type of training you're doing. So this can sometimes be a cause of tendinopathy. So what is load capacity? So your load capacity is essentially your ability to be able to perform without pain. So like for the climbers in this call, like can see whether this sounds familiar to you, that I just climb every day for the last week after lockdown. Not sure when it happened, but it hurts a lot when I wake up in the morning. Or like my 1,000,000th day climbing in a row, I'm perpetually tired. My elbow started to ache, but it was mild. I ignored it, and now it's painful to even like clench your fist or even like day-to-day activities. So the main point of saying this is that every tendon has a certain capacity, and a tendon injury essentially can occur either at a chronic or acute overload. So yes, when the climber has done too much and too soon. So when to load and when not to load. So for this, timeline matters a lot. So in the acute stage, it's early load management is very important. So a reactive tendon has a potential to get better or worse very quickly. And then when you get onto the second stage, this will not be the first time they experience this pain. So it often occurs when you go again too much too soon, also known as the boom bust cycle, which we will go through a little bit more on that later. So essentially your capacity is overloaded, the pain comes back, and unlike other tissues, it's very tricky to determine what your tendon capacity is because it's very different. It's a very subjective measure as opposed to like muscle bulk recovery where you can do isokinetic tests or circumference of your muscle or like pain score. So these are all not good measures of what your tendon capacity is. And then for chronic, this is when it's been going on for like 1,000,000 years and you just keep going back and forth and back and forth. So it's very important to note that this is not a linear progression. So your stages can be jumping in between frequently. So for example, at a chronic stage, it's very normal to have a reactive or acute flare-up again, and then you have to go through like these cycles again. So what we're talking about in the boom bust cycle, essentially it's when you have too much too soon. So there's a period of excessive loading followed by a period of underloading. And then when the capacity is not restored, you go too fast, and then after that your injury flares up again. So a simple way to think about it, it would be like an analogy of poking onto a bruise, that if you stop poking, there'll be no inflammation and there'll be no pain. But that doesn't mean that there is like your tissue still does not have the capacity to take that new load, because with every tissue injury, you're not doing anything to it, it keeps getting weaker and weaker. So by saying that, it's more towards how pain shouldn't be used as a measure of improvement or measure that you're recovered. So second part would be on finger pulley injuries. So I won't go through too much of this because the previous speaker already went into it, but then I suppose from climbers' perspective, I think it one of the things that I find that climbers usually ask me would be whether or not it's a pulley injury versus a tendon injury, or for example, their lumbricals. So I would say that a good way to determine what it is would be firstly your mechanism of injury, whether it's something that is a sudden overload. So for example, if you hold on or catch something and then after that you have a sudden slip, you hear a pop, then that would be a main feature of what a pulley injury is. And then for your tendon injuries, it will work actually similar to what we were talking about for tendinopathy. So this can happen when, again, you through overuse or through the boom bar cycle. So generally, in terms of pain-wise or in terms of how you load, there can be some defining features in the way that if you crimp and hurts more as opposed to open hand grip, that can also point out to a pulley injury. So this one was mentioned before, so I think these pictures are just for you to better understand how much load actually goes into a joint when you are crimping onto something. So for climbers familiar with different kinds of grip, generally open hand grip is considered the safest, most ergonomic way or healthiest way of how you should be loading your tendons, because once you go into a crimp grip position, there's about 30 times more force on your pulley systems. So your crimp grip or close crimp should only be used as something of a last resort if you really need to hold on to it, but it shouldn't be something that you're using constantly. So the third part about injuries would actually be on overtraining. So the general adaptation system is how our body responds to stimulus and how essentially each of us gets stronger. So it was originally proposed by Hans Sly, I might be pronouncing it wrongly, but essentially alarm is when you first, start a new, for example, training regime, like if you're doing weighted pull-ups, and then your body recognizes that new stressor, and then it goes into resistance where it starts to cope with the stress. And this is also where supercompensation happens. So it's essentially when proper programming, given that correct amount of active rest balanced with the correct amount of fatigue, helps your body adapt to that new load so that each time when you go back to train, you're ready for that new weight. And exhaustion is when your stress continues. Stress would mean more towards at this context, like physical loading. So if you are constantly stressing your body without recovery, then your body breaks down. So the key to this is to avoid reaching the exhaustion phase by having proper programming, proper structure with rest and deloads. So another way to look at this would be through overreaching or overtraining. So it's essentially the same concept that you are, but looking at it in a more holistic way that your body reacts to it in physiologically. So functional will be again short-term fatigue, possible supercompensation, and then non-functional overreaching is essentially what we described just now as exhaustion. And overtraining syndrome is that stage you reach when you're in that constant state of exhaustion. So this is actually more even though it sounds very say generic or it's just someone overtraining, but once you reach overtraining syndrome, your body actually physiologically changes a lot, and it can take up to 8 to 12 months for you to be able to get out of this stage. So at this stage, your body is just in a constant exhaustion phase. Your nervous system starts to deregulate, you get poor sleep, irritability, and building on that, your tendons and connective tissues get very vulnerable because they don't get enough time to repair. So even doing something very low load at your sub-maximal climbing level can also cause injuries at this phase. So along with that, your muscle strength, endurance, coordination, immunity can all decline. And then it reaches just that constant cycle of fatigue, low mood, and yeah. So recovery. So I'd say that most climbers generally don't really know how to rehab or recover, and this is also largely due to the erratic nature of the sport. So as compared to most regulated sports, like for example football or I guess basketball, that there are different stages where you know when to return to training, when to return to performance, or when to return to sport. But for climbers at least, they used every session kind of as a performance session that they have to do well, or they max out every single session. So these are some rehabilitation principles for you to possibly look at as a different way of looking at your rehab process. So using irritability to guide your process. So how much is considered as too much? So carrying forward the concept of capacity. it plays a large role of balance, load, injury, risk management, and eventual return to sports. So when I talk about load in this context, it is sport specific. So overhead sports will look at, for example, number of throws, the velocity of throws. Endurance sports will look at heart rate, your distance. So due to the variability of climbing, it's very hard to have one single metric that you use to kind of objectively measure how much load that you have, because every attempt, route, session will always be different. So what we can look for instead is, for example, a number of routes that you are doing. So everyone has maybe about 10-ish warm-up routes before they start doing something harder that session. So one objective way would be kind of to classify the intensity of the route that you're doing. Then another way would be number of uncontrolled latches, or number of, for example, if you have a wrist injury, how many slopers have you held that day? Or if you have a pulley injury, how much crimps you've held that day, or number of dynos. So these external loads are objective way for you to, example, like cut off that if you know you have a wrist injury, you can hold maybe maximum like 5 slopers during that session. So that's your external load. And then the internal load will look at the relative biological stresses. So both psychological and physiological. So for example, using pain scale as one measure. So for example, how many times, or how 0 to 10, how much did it hurt? What was the worst pain of this session today? Or how much did I exert my injury area today? So this one, I would recommend using it as kind of subjective layering on top of external load, because with climbing, it's usually more retrospective, and by then your injury is probably a lot worse already at that point. So another concept that you can keep in mind when thinking about rehab is that a stress shielding phenomenon. So this is the way that our body reacts to injuries. So during an injury phase, during a normal muscle, your load is evenly distributed, like vertically through the collagen fibers. But then when there's one injury, which is like that red arrow over there, then the way that your muscle kind of regrows around it or kind of transmits the load is different. So for example, if you see like 3 strands over there, the red one is now down, so all the load goes in the 2 of them. So essentially, it's when the load and stresses would go around the area that is damaged. So if you're trying to heal it, you need to load it, but then every time you load, you kind of go through this stress shielding phenomenon that you need to find the right balance. So for example, in tendon injuries, doing this thing called stress and relaxation, so pulling and holding will allow the strong fibers to relax and then allow that injured red arrow tendon to be able to recover. So the next part is about what is the right exercises for you. So on the internet, there's like many exercises or rehab or websites as to tell you what to do. So it's important to know that not one size fits all of them. So what works for your friend might not necessarily work for you. And just as an extra note that for any lower body injuries, it's very important to include plyometrics in your rehabilitation, especially if you're doing bouldering. And on training the brain, so one part about this is that because with every injuries, it will invoke changes in the cortical areas of your brain and lead to fearful movements and anxiety in the climber. So for example, if you maybe pop the pulley, we've all experienced like kind of cringing when you watch a climber slip off like a crimp, or like do a really big drop knee when you have your own knee injuries. So chronic injuries tend to build on this kind of fear avoidance cycle, and it has the potential to manifest with physiological changes in your neurocircuitry. So essentially, if you are thinking about something else and you're not 100% focused on the root, that is when you're probably going to get injured. So, but there's a large scope of this, going to like sports psychology and injuries, but that would go outside the scope of this. Right. And the last bit would be on, are you really ready to return back to sport? So this was what I was talking about previously in terms of returning to participation, returning to sport, and returning to performance. So most climbers tend to skip the first 2 phases, and after like 2 weeks of rehab, they already go back into climbing in terms of the level that they were performing before. So in a climbing context, return to participation would be getting out of that acute stage. You make it up to the gym, you start to do your rehab exercises. So this would have nothing to do with you getting on the wall. And then return to sport would be climbing at your sub-max level for relatively maybe about 4 weeks. So there shouldn't be anything that you feel like you're punting off or that you have to exert really hard. It's a lot on letting your body adapt to, for example, movement, for example, on falling. So this part is very, very important and most of what climbers miss off. And then return to performance is when you can start climbing hard without thinking about anything. Like you don't have to wear knee guard, don't have to think about I have a tweaky knee, I shouldn't be doing heel hooks and stuff like that. And last bit is that there is many frameworks for you to be able to guide decisions. So currently right now, evidence-wise, there isn't a framework developed for climbers yet, but then there are a couple of them that look at, for example, reverse overhead, so like gymnastics or overhead sports, that there are standardized tests out there that would be able to give you kind of an idea to how objectively sport specific really you are. So the table on the right that I have is looking at your shoulder injuries with overhead sports. So there are many tests, like for example, doing like push-up with claps, seated medicine ball throws, or the IYT test that will be able to test your shoulder stability to be able to kind of give you that extra objective confidence that my joints are like good enough to climb. So it's I think, and sorry, the one on the left one essentially is a guideline into what I mentioned about before, but just broken down on a physiological level in terms of returning to sports, returning to participation, returning to participation, sports, and performance. So if any of you are interested in looking a little bit closer at these, you can let me know, then I can send you over the papers. Right, so in summary, it's important to be aware of different healing timelines for different types of injuries also. So for example, an ACL injury, recovery will be very different from a tendinopathy injury versus a fracture. So this one all depends on the biological state of the tissue itself. And when looking at, for example, tendinopathies, context is crucial and timeline is key. So is this an acute once off? Is this a chronic flare up? Is it just the local tissue itself, or why are you constantly getting flared up in that area? Is it more towards an issue with, for example, your shoulder mobility, strength, or kinetic chain training? And also, importantly, what type of climbing are you returning to? So going back into bouldering, for example, it's very different from going back into lead climbing. And lastly, on your risk tolerance, that are you prematurely returning because of like external pressure, because you feel like you're missing out when your friends are climbing? So is there actually a reason that you need to go climbing right now? Like, is there a competition coming up, or are you just using, I guess, the power of belief to mask your injuries? All right, and I think that's about all I have. Yes, that's all. Thank you.